Вітаю! Greetings! Welcome to the continuation of the EU-Ukraine webinar series on spinal dystrophism. This webinar series is hosted by ERN Eurogen and supported by International Federation of Spina Bifida and Hydrocephalus and OmniNet Ukraine. This webinar is eligible for EICME accreditation for those who attend the live session and complete the post-session survey. To our Ukrainian participants, in the event of an air raid alarm in your area, please take shelter immediately. A recording of the webinar will be available later. Today, we will talk about long-term complication of surgical reconstruction of lower urinary tract. Our today's outstanding speakers is Professor Roger Dmochowski. Also, it's my pleasure and privilege to introduce my co-moderator, Professor Giovanni Mosiello. Professor Mosiello, the floor is yours.
Thank you, Professor Zymak. Welcome to all, and welcome to this new webinar. And we are very proud to have today with us Professor Roger Dmachowski, that is a professor of the Department of Urology and professor of surgery, professor of aesthetics and gynecology at the Vanderbilt University in Nashville. He's also professor in surgery at University in Bethesda, Maryland. He's associate surgeon-in-chief, vice chair, a section of surgical sciences in Vanderbilt University. He received his medical degree at the University in Texas, completed an internship in surgery, urology, and additionally is trained in female urology, neurology, urodynamics, and reconstructive urology. He published more than 400 peer-reviewed papers, more than 100 book chapters, and is the editorial board of the World Journal of Urology, reviewer of Journal of Urology, and is the editor-in-chief of Neurology and Urodynamics. He is a trustee of American Board of Urology. He received granted several awards by different societies. His mainly interest are outcome on incontinence treatment with a particular emphasis on quality of life issue. This is a point that could be very interesting for our patients. So I'm very proud to introduce his presentation with his lecture on long-term complication in spina bifida patients. Please, Professor Dmachowski, the podium is yours.
Good day. My name is Roger Dmachowski. I'm a urologist at Vanderbilt Medical Center in Nashville, Tennessee. I'd like to thank you for the opportunity to present to you and to the Ukrainian Brotherhood, and I will speak more about my personal connection to you at the end of this discussion. I'd also like to thank Giovanni Mosiello for the opportunity to present this topic to you this evening. My topic is long-term complications of surgical reconstruction of the lower urinary tract. And this is a very difficult topic because it incorporates numerous concepts that must be discussed in order to best understand how we can report the complications in a fashion that is understandable and reproducible for our colleagues and our patients and for the science of medicine. This is my conflict of interest. I am a senior medical advisor for a neuromodulation device company. So there are several areas that I'd like to discuss with you tonight related to topical points for this conversation. One is how best to identify complications, and of course that involves a high index of suspicion that is associated with a perception either by the practitioner, the patient, or both that perhaps the patient's course is not what was anticipated normally with the associated intervention. We also will discuss categorizing outcomes and some of the derivatives from that categorization that have occurred for specifically the pelvic floor, since that's really what we're discussing is long-term lower urinary tract outcomes. how to assess and optimize accurate reporting, and then also the management of unique issues, as these all are very important concepts in this discussion of the long-term complications and outcomes of lower urinary tract interventions. So, what is a complication? Well, complication, as we look at the definition, comprises risk as well as benefit as well as the potential for complication. Surgical risk is simply defined as the potential adverse for medical circumstances that may arise from having surgery or the dangers or harm that may occur from that intervention, procedure, or surgery. Risk are the surgical factors which provide the set of circumstances that increase the risk of surgical complications. So the best analogy for this is those patients with multiple comorbidities, for instance, such as poorly controlled diabetes, and the importance of understanding those contributing morbidities and comorbidities to overall risk of a procedure. And finally, surgical complications, which of course are any negative medical consequences that deviate from what is expected outcomes of a surgery under a reasonable expected scenario. So complication obviously encompasses not only the complication itself, but the risk associated with that complication as we discuss these interventions and risks of our interventions going forward. So who determines the complication? Is it the proceduralist? Is it the patient or family? Or is it the health care system or hospital that we work in? Obviously, there are other entities that also determine complication and risk, including the government and payment entities such as insurance companies, and finally the legal system. Unfortunately, when complication is defined by anyone outside of the dyad of the proceduralist and the patient and family, then we have real concerns as to why the complication is being defined and how it is being defined. Certainly, government and payment entities have a real focus on monetary compensation and monetary loss. So their definition for complication may be heavily influenced by overall cost associated with that complication. The legal system also has a monetary benefit for defining complication, and obviously that benefit is that which affects the legal representation of the patient or family that has perhaps had an uneventful or rather an eventful or untoward outcome, and therefore those definitions, although important, perhaps are not quite what we think of when we think of complications pertaining to lower urinary tract, and for that matter, any surgical or procedural intervention. We know from very good work done now well over 2 decades ago that a variety of grading systems have come forward to essentially determine the level of complication. The level of complication obviously being defined by not only the alteration of the patient's course associated with that complication, but also the modes of therapy associated with those interventions and complications. And so you'll notice in the Clavien-Dindo system, which is now internationally recognized really as perhaps the foremost system to grade complications, much of the definition is defined by the derivation or the deviation from normal postoperative course and care. Obviously, as these deviations occur, then interventions are required that are of various degrees. And clearly, the difference between grade 2 and 3 is when there's an alteration of the course of healing or course of postoperative convalescence for the individual that then requires some form of significant intervention, those interventions either being surgical or those interventions that subsequently result in long-term consequences such as single organ dysfunction or multi-organ dysfunction, and finally, obviously, death. Within the realm of pelvic floor medicine, we've learned a lot from our experience with surgical reporting for mesh-related complications. And I present to you the International Continence Society and International Urogynecologic Association categorization, taxonomy, if you will, for mesh-related complications. And I will spend the majority of this evening talking about mesh complications, as they have really formed the, if you will, the substance of knowledge that we now use perhaps for other types of technologies as they come forward. And we do live in an era where we are increasingly being offered new technologies, whether they be heat-based technologies or pharmacologic-based technologies or stem cell and biologic-based technologies that substantially may alter the course for our patients, but we have to be aware of the risks associated with the potential course alteration that these new technologies bring. So as we look more specifically at the IUGA-ICS joint terminology classification, obviously what's very important is definitions of what is the intervention, in this case, what type of implant is being used, what type of graft is being used, and of course, as we all know, we have experienced and experimented with a great number of graft types, including quite a number of different xenograft sources, some of which have failed miserably, some of which still are used especially for skin coverage, such as, for instance, porcine small intestine, which still may have some indications for specific lower urinary tract indications. Obviously, there are other terminology definitions that this document includes, including the difference between exposure. For instance, when a mesh product has essentially presented outside of the epithelium, versus extrusion, where the actual mesh or biologic graft or whatever material it is has been gradually passed out of a body structure or tissue. So these are very important differences. And then, of course, we have dehiscence and perforation, which are also very important when we consider some of our graft healing processes. The other important aspect, especially when we consider grafts or pelvic floor dysfunction, is exactly where did the graft or mesh or implant cause problems. And so obviously we need geography. We need to consider vagina or urinary tract or GI tract, or for that matter, skin or musculoskeletal system, and the degree of patient compromise associated with that. And so this categorization, at least in my frame of reference, has been a very useful touchstone to help standardize our literature reporting, and also to bring forward a method by which we can compare various studies across various different intervention types. One point I really would like to focus also on in this particular categorization is the importance of time. And you can see they have broken time into 4 elements: intraoperative to 48 hours, 48 hours to 2 months, 2 months to 12 months, and over 12 months. And what's becoming clear is the over 12 months is a very interesting time. And one of the things we're learning from mesh is that, in fact, it may be years before a complication presents. And just recently, our colleagues in the United Kingdom have presented a national database with 90,000 mesh-related interventions and complications, 90,000. And those complications, although of course are most commonly seen up to 85 or 90% within the first 12 months, there is a long presentation curve for the remaining complications out to 8 or 9 years. So, and that's not only because of patient failure to report, it's also because of delayed presentation of the complication. So time is a very critical aspect of chronic outcomes reporting, and one that must be standardized across our various reporting structures. So, as we consider the types of complications, we also have to consider how is a complication defined and what contributes to a complication. So complications may be clearly objective and measurable phenomena. Certainly the appearance of a fistula after an incontinence procedure or a prolapse procedure is a significant measurable phenomenon, as are such simple things as, for instance, urinary tract infection. And clearly when we look at our experience with more minimally invasive interventions, such as, for instance, urethral bulking, the reporting of urinary tract infection becomes very important. What also is a measurable type of complication that is objectively measurable is the requirement for treatment, either hospital readmission, reoperation, or for that matter, even medical treatment. But I'd also like to suggest that a complication is a surgical failure, such as immediate incontinence occurring after an incontinence procedure that for whatever reason didn't accomplish the goal of even improvement of incontinence. And then obviously the immediate recurrence of a fistula, both of which indicate some form of surgical failure, whether it be technical and host-related or purely host-related. These immediate failures are a major contributor to complications, certainly as we look at large reporting groups who have presented this data historically. But in addition to objective data, there are subjective data that we must consider when we report complications, especially long-term complications. Patient-centric symptoms are critical. Pain, dyspareunia, changes in the function of the various organs of the pelvis are very critical when we consider lower urinary tract reconstructive phenomena. Obviously, these patient-centric subjective criteria are often measured by scales, such as a visual analog scale for pain. Various urgency metrics exist. For instance, there are now GI metrics that exist for changes in stool and bowel function. And obviously, there are sexual dysfunction scales that help us measure sexual dysfunction. But in reality, we are very dependent on the patient input to the questionnaire or quality of life data set that we're using in order to understand these patient-centric outcomes and at least partially define them from both a baseline standpoint and also a long-term standpoint, considering treatment interventions that may attempt to remediate those complications. Another contribution to complications, long-term complications, and one that we have to keep in mind is lack of patient comprehension of intervention. In other words, the patients didn't understand the risks and benefits of the procedure, or the patient is dissatisfied with the outcome because perhaps they had unrealistic expectations. So these, again, are very, very important considerations as we consider subjective criteria that contribute to overall long-term outcomes reporting and complications reporting. So, as I mentioned, time-based reporting limitations also have previously, perhaps historically, affected our ability to perceive and detect risks and rates of outcomes and complications. Many journals now require a minimum of 12 months reporting, associated also with a minimum criteria for outcomes and accepted definitions for those outcomes. Increasingly, we're now seeing national and study group reporting for pelvic floor and urinary incontinence procedures of 36 to 60 months. And this especially is being noted in national registries, for instance, in the UK and in some European countries that are doing a very good job of maintaining national registries. It's one, I think it's one item to keep in mind of the initial results with an intervention, but these long-term general use results are also critical to understand the true impacts of both old and new technologies and the ability to capture those. As I note, there is rare reporting for longer than 5 years. There will be an occasional report, and I'll give you a very good example of a study that is now a decade or so old from the Karolinska, which looked at their 30-year results reporting for urethral diverticulectomy. And one of the interesting things from that particular paper was the report that approximately 30% of patients had de novo or recurrence of their diverticulum over time, indicating that although we take care of the initial lesion often very well, the problem is our field in terms of urethral diverticula is affected by poor fascia and the risk of recurrence with time. So very important results that unfortunately these longer term data are able to give us but are rarely captured. So let me digress and use pelvic floor meshes as an example of lessons in outcomes, because I think it's a very important consideration for those of us who are urologists, urogynecologists, and pelvic reconstruction specialists to understand how this became as popular as it did and where errors were made. So why did mesh become widespread? Well, there's a variety of reasons. There was suboptimal durability of many of our pelvic floor interventions associated with long both operative and convalescence time. And there was substantive morbidity associated, especially with some of the pelvic procedures, such as the retropubic suspensions, as well as, for that matter, pubovaginal full-length autologous slings. Typically, post-pelvic organ prolapse surgery has been also a technically complex operation, primarily done by gynecologists, again with suboptimal durability, again with long OR time and convalescence and long morbidity. As we know, Olmsted first popularized the concept of the integral theory in 1993. And in 1996, this brought forward the TVT, which initially was developed in Europe and, of course, then spread internationally for all patients. And again, the concept was to recapitulate the support that perhaps had occurred with the urethropelvic ligaments with time and with subsequent aging-related changes and parturition-related changes to the pubovesical ligaments. Those ligaments and urethropelvic ligaments actually became weak and allowed rotational descent of the urethra and urinary incontinence. The mesh was brought forward as a way to recapitulate that support and obviously potentially mollify and manage the condition of stress urinary incontinence in women. It was considered ideal for surgeons and for patients. For surgeons, there's a variety of attributes that allowed this procedure to be brought forward, including its simplicity, its short operative time, and the fact that its efficacy and durability compared very favorably with historic native tissue repairs. It was ideal for patients because anesthesia could be minimal. It could be done as an ambulatory patient procedure. There was rapid convalescence and supposedly less pain. And then this brought forward an evolution of various types of slings, the retropubic down-up versus the up-down. Most urologists are more comfortable, obviously, with the up-down versus the down-up, which, interestingly enough, is much more focused in urogynecology. Subsequently, because of the early successes of meshes, and you can see the dates, we're now speaking of 2 decades ago, the transobturator mesh was brought forward as being one that was potentially associated with less risk and also had a variety of insertion techniques, including the in through out and out through in, and was thought to be very rapidly progressive from a convalescent standpoint and very acceptable from patients. And finally, the last iteration of the meshes was the single incision sling, again associated with potentially less risk for the patient, less pain, and less anesthesia. And so therefore, we saw a rapid acceptance of midurethral slings and other meshes, especially in certifying patients, certifying urologists who were seeking board certification in the United States. And it became the dominant procedure in female stress urinary incontinence amongst surgeons, urologists applying for board certification in American urology, which is very, very interesting from the standpoint of understanding the impact of the meshes on clinical practice. This resulted in increasing use of midurethral slings over time, and midurethral slings essentially exploded, as this graph shows, on an annual basis, with a few other procedures such as bulking, and the lowest curve is retropubic suspension still being present. And again, this technology was very robustly accepted by a wide variety of clinicians, not only those who were considered experts in this field, but also generalists, general urologists, general gynecologists who perhaps were not experts in the world of female pelvic health, but were certainly surgically boarded and could adapt these techniques for their own purposes. Subsequently, also associated with the development of meshes for stress and incontinence became the development of transvaginal meshes for pelvic organ prolapse. And these mesh kits associated with large volumes of mesh to reconstruct the anterior and posterior compartments came forward, with the first kit being presented to the general public in 2002, and then with multiple other types of kits brought forward. And each kit had its own nuances and anchoring sites. You can see the various types of implementation. And interestingly enough, from the standpoint of the implementation, despite the difference in curvature and spatial context of these various trocars, they're all considered similar when the regulatory authorities evaluate these. Rightly or wrongly, a trocar is a trocar is a trocar. Additionally, not only were the insertion devices somewhat different, the anchoring areas were also different. And you can see the sacrospinous ligament was a common area of fixation, as was the iliopectineal ligament, as was the other ligament and fibrous structures in the pelvis. So the development of these procedures actually proceeded very rapidly with very minimal clinical experience, at least initially. And again, associated with and similar to the uptick in utilization of pelvic mesh for stress incontinence, as you can see, meshes also increased dramatically for the management of female pelvic organ prolapse, and you can see the rapid rise in the use of meshes for these procedures. Again, done for the purpose of trying to increase durability of the native tissue repairs, which are generally recognized as being deficient in terms of long-term durability. The US FDA increased and approved multiple other types of products over the years, and you can see the rapid increase from the late 1990s through the 2000s, with multiple devices and products being produced for purposes of both stress and prolapse therapy. Mesh was utilized by a variety of companies, and you can see in the U.S. market and some European markets the number of companies that were present and their contribution to the various attributes of these various meshes for both indications. The number of meshes, there was an increased use of meshes and an increased number of adverse events reported, with numbers increasing rapidly over each annual year. But these were not mandatory reporting, these were voluntary reporting structures, and therefore we really had no idea what the ultimate reporting was. And there was strong evidence that actually there was underreporting of meshes and mesh complications over time, which again represented one of the problems with the long-term management and identification of complications. And one of the most important points that I'd like to note tonight is that before management, we must identify the complication and be aware of it. And so part of our awareness is our own personal and group education related to the risks and types of complications. These were the type of complications that reported, and you can see this was in the early experience, but it covered the first decade or so of the complications associated with meshes for pelvic organ prolapse. You can see the erosion rates of 30%, 35%, the pain rates of 31%, significant infection rates of 16%, and then other rates of lesser percentage, but again, numbers that are really significant in terms of specific concerns such as organ perforation and also obviously things such as vaginal scarring and stenosis, clearly which are problematic for our patients. And how did we become aware of this? Well, much of this was based upon our own, if you will, individual anecdotal recognition. So this is an exposure of a mid-urethral sling. Notice the just small area of exposure at the level of implant in a patient with marked vaginal atrophy, consistent with poor wound healing in this area. We saw other more significant aspects of mesh exposure. This was one of those large sheets of pelvic mesh, and you can see the large area of mesh exposure on the central anterior vaginal wall, consistent with the exposure of the mesh completely through the wall. These actually were very problematic for patients because many of these individuals developed significant stenosis of the vaginal vault, but they also developed significant pain and dyspareunia associated with these exposures, which required not only excision of the mesh, but also, unfortunately, required subsequent therapies for chronic pelvic pain. As you're well aware, based upon minimal data, some surgeons recommended complete excision of all mesh in the individual. Some individuals, such as myself, recommended only excision of the areas of mesh immediately associated with the erosion because of the risks of morbidity associated with the much more enlarged removals of these large pelvic mesh sheets. And it became fairly recognized, again, anecdotally, that long-term complications were associated with volume of mesh implanted. So these large sheets were a concern, and that was not recognized as a concern until, unfortunately, these complications occurred. But also these large sheets of mesh were problematic from the standpoint of contracture. And these meshes, although initially thought to be placed without tension, often with the healing process and patient movement were subjected to tensile forces with patient movement. And those tensile forces created, if you will, very stiff tissue or stiff material under the vagina, which enhanced or made the exposure experience much more rapid. Again, another type of mesh exposure. You can see the mesh there, and again, this is an example of a anterior mesh that was problematic in terms of what it produced. And again, this is unfortunately also related to fistula formation. So not only in this case did the mesh extrude, but it also eroded into the underlying viscera, in this case the vagina, resulting in a vesicovaginal fistula, which you can see very nicely portrayed there. Also, meshes were unfortunately found in both bladder and rectum in many hundreds of patients. And this was thought to be due to a variety of risks, but it became clear that one of the most important concerns with mesh exposure or mesh erosion was not that the mesh had eroded, but technically had been placed there at the time of the procedure. And one of the faults of the initial introduction of mesh was in order to have more mesh utilized, physicians were instructed that cystoscopy was not an important part of these procedures, and that was definitively a wrong instruction. Patients should have been cystoscoped at the time of insertion to recognize acutely if the mesh was there, to remove the mesh early to avoid some of the complications associated with long-term mesh placement in the bladder, including recurrent urinary tract infection, and as you can see in this case in the lower left, of mesh incrustation by calcification, which became very problematic. So out of this experience, a separate field of mesh management arose, and a variety of experts commented on this in terms of the complications of pelvic mesh excision surgery. So we have the complications of pelvic mesh insertion, and now the complications of pelvic mesh excision surgery. And again, looking at a large category of patients, a large grouping of patients that was analyzed, 277 patients were identified, of whom 132 had no complications, just under 50%. But then you can see the rating of complications with mesh excision going up in rating up into very significant complications in around 11% of patients. So these are very problematic type occurrences, and this is related to attempted mesh excision. And what were some of those complications? Those included such things as de novo stress incontinence, persistent urge incontinence, a variety of surgical-related complications, ureteral injury, severe dyspareunia, bladder outlet obstruction, bowel injury. All of these, again, an experience not only of the primary mesh, but also of the attempt to remove the mesh that was causing problems, which induced more problems. So again, as we look at long-term complications, we have this stepwise, if you will, assessment or experience with mesh from the complications and issues associated with the primary implant to complications and issues associated with the attempts to revise that implant, hence the discussion about total versus partial mesh removal in patients. And again, you can see that many of these complications were related to the initial indications for the procedure, including urinary incontinence, and many did result in de novo presentations. And again, this was relatively short-term follow-up, certainly within the year after the mesh excision. And finally, the ureteral injury and iliac vein injuries are injuries that are obviously life-threatening and obviously are associated with much more complicated mesh-related fibrosis and mesh-related resection concerns. So groups reported, and here's one group, many of us were involved in multiple of these groups, reporting the outcomes of autologous fascial pubovaginal slings for patients who had had transvaginal mesh-related complications. And so many of us became quite expert at subjective success for, if you will, salvaging these patients with autologous procedures after they'd had a primary synthetic procedure. But notice the complications, although they were low, there was still a 1 in 10 complication risk, which is something that we have to keep in mind and certainly advise our patients about. So why were there so many complications with mesh? What's the problem and who's to blame? Well, there's been a variety of discussions related to this, but we ourselves bear some of this burden. Certainly, the entities who made mesh perhaps trained too many new implanters initially and perhaps gave them suboptimal indication. And both the Royal College and the American College of Surgeons have now established minimum criteria for surgical education, for new techniques, for post-training surgeons who are trying to develop new skills. And these techniques and courses are really founded on establishing basic understanding of that particular surgeon's experience, providing the appropriate didactic and educational material, and also providing some form of exposure to the actual procedure, both in either a dry lab or a wet lab, followed by some form of mentoring experience when the surgeon actually brought the procedure to their institution. Obviously, there were problems with the way the mesh-related complications were reported and also detected. I don't feel that this is only a regulatory governmental concern. I do feel that this is a societal concern. I'll give myself an example. I did quite a bit of full pelvic mesh reconstruction for patients with pelvic organ prolapse, in other words, cystocele and rectocele. Very early in my experience, within the first 3 years, I was seeing a 20% erosion rate, and that's what drove me away from using meshes. So, and I should have reported that. I didn't, and I think it's very incumbent upon us as practitioners to share our results in a transparent fashion so we can educate each other about what's true and what's not. And then what about surgeons? Obviously, many of our young surgeons weren't trained in these particular areas of intervention. And certainly when I refer to urology, still for lower urinary tract reconstruction, many urology training programs, especially in the United States, are deficient in urologic exposure, urologic reconstruction exposure. It's getting better, but it's still a problem. And then patient selection is key, and not every patient who has a condition should undergo surgery. And so it's not only patient selection, but knowledge of the pathophysiology of the disease and what are the best options for the individual, and recognizing the suboptimal candidate and having a discussion with that individual about the suboptimal nature of their risk and the potential for having significant complications thereafter. Again, the informed patient is the patient who is best managed when a complication occurs. Or what if we discuss the mesh itself? And again, as I mentioned previously, much of our experience with new technologies is acute. It's relatively early, and as we become more mature with our experience, so does the understanding of what that experience for the particular new technology is. So for meshes, there were obviously a variety of meshes which were initially sort of considered as one group. They were all the same. But mesh experience and mesh intervention and also engineering educated us that not all meshes were created equal. So some meshes degraded. This wasn't so true for polypropylene mesh, but certainly some of the other types of mesh, dense weave meshes, were subject either to encapsulation or degradation. And that degradation obviously could have an effect on overall structural integrity of the mesh and structural dependability of the mesh. So again, as we talk about complications, these type of degrading phenomena actually could occur quite early after the implantation. And this sort of degradation was actually experienced very early in some of the alternative biologics, such as the xenografts, which I personally had significant experience with, especially some of the cardiac xenografts that were used for pelvic reconstruction that had early failure rates due to exactly this problem, degradation. But other issues impact meshes, and another is the host response or immunologic response. It's fairly clear that when patients have chronic inflammation, they do develop an immunologic response. It has now been dispelled that that the patients develop, if you will, an allergy to the mesh or the implant, but there is a host response that can be very chronic and very problematic. Some have claimed that there's even a risk of carcinogenesis with these types of materials, and this has been reported and has certainly been identified in some animal models with certain types of mesh products. So these are all considerations that we have very little substance to measure in our animate human experience. So of the materials, many materials related to polypropylene meshes have been, again, if you will, associated with autoimmunity, carcinogenesis, degradation, and certainly an infection. And a word about infection. Infection is associated very clearly with certain types of the dense weave meshes. The dense weave meshes, such as Gore-Tex grafts, for instance, and vascular grafts, are unable to actually have permeation of tissue cells through them, and therefore become essentially, if you will, a privileged site. And again, given the relative problems with sterilization of the vaginal canal at the time of surgery, we did see significant infection rates associated with these dense weave meshes that were very problematic. This became a significant area of discussion in the most recent international consultation of incontinence which was completed in Tokyo in 2017, and a lot of discussions related to these, but ultimately they were all unproven, except for the degradation risk associated with some biologics and the infection risk associated with dense weave meshes. So is it the surgeon or is it the complication? Well, there have been several reports of patients and looking at the type of original operative note and then what happened at the time of re-exploration. And some surgeons have been brave enough to report their own. Some patients have, some sites have reported experience with implants removed and what the original operative note stated. And again, original operative notes, unfortunately, are not always accurate, and things such as perforation of vaginal wall and perforation of bladder are perhaps not always indicated at the time in the operative note. And so oftentimes we do run into complications associated with meshes where a complication in the initial insertion may have occurred, but it was not identified by that surgeon. So what are the indications for re-exploration in many of these cases? Well, obstruction is perhaps the most common. This is obviously associated mostly with midurethral slings, but also in some cases with anterior vaginal wall meshes as well. Obviously, the pain is a very significant problem. Almost 30% of patients have pain, and my personal experience is, although you can improve the pain, there are some patients who develop global pelvic pain, and that is not remediable by surgical intervention. Obviously, erosions and extrusions are another key aspect of these various types of mesh experiences, and recurrent urinary tract infections, not surprisingly, are associated with erosions into the genitourinary tract. These erosions can occur immediately, but I have seen patients who've developed erosions as late as years after the implantation. Again, indicative of the fact that we really need to follow these patients long term to assure that we're not dealing with complications that arise and are not appreciated. There is a clear indication that there are improper techniques utilized at the time of implantation. So one of the things that's really critical is being honest about urethral injuries and other types of injuries at insertion. One of the most important things we learned was you cannot place mesh over a urethrotomy that has been closed. It's 100% risk of erosion. So it's very important to keep in mind that urethral injury should not have mesh placed over it. Why do these occur? These are texts from various operative notes, again indicating that the injury was relatively acute when it occurred. Obviously, the variety of terms were used that are, and I don't want this audience to really spend much time noting, except that when mesh is placed under tension, which the word snugly implies, that really does cause the risk of urinary tract obstruction and the associated risks of retention and urgency associated with that. So all of these are essentially indicative of poor technique, and again are reflective of the fact that we need to do a better job of surgical training for our new trainees, as well as those surgeons who are fully trained but are acquiring a new technology. So what about reoperative findings? Again, looking at a large number of patients who had been identified with complications. Again, location of and insertion of the sling material or the prolapse material is a source of complication in many patients. Too deep of insertion, again, the mesh cannot be inserted too deeply because it is much associated with damage to underlying structures if that's caused. And then this issue about tensioning that I mentioned is very critical. Again, technical error associated with tensioning is one of the most important risks that patients face, and so tensioning with these meshes must be done with essentially no tension applied to them. So in this particular study, 70% of midurethral sling complications were associated with factors that were remediable at the time of insertion. So again, although we're focused on long-term complications, our long-term complications unfortunately are initiated by some of the short-term technical errors that result at the time of the mesh insertion. So there's another 33% of patients who have complications that aren't related to technical complications. Why is that? These may or may not be the mesh-related complications. They may be related to appropriate patient selection and indications for surgery. And again, it's very difficult to identify them based upon review of source documents. It's amazing to me the number of times patients undergo a stress incontinence procedure with a predominant complaint of urge incontinence. That's the wrong indication, obviously, for these patients. So again, when we consider why complications occur, would the results have been similar or worse if native tissues have been used? And again, we have to compare, if you will, same number of cases being done with native tissues, same surgeons doing them, same level of scrutiny, and same assiduous nature of follow-up. So at this point, it's hard to say that we wouldn't have seen significant rates of complications with native tissue repairs if native tissue repairs had been done at the level and numeric frequency that was associated with mesh repairs. But clearly, there is the mesh, and then there's the procedure the mesh is used for. And we know that procedures done in the pelvis are associated with de novo stress, de novo urge, dyspareunia, pelvic pain, and other complications, including urethral obstruction, even without the presence of mesh. So these are long-term complications that we have identified historically and should be aware of. And so it's very important to view the experience with mesh in light of those long-term complications associated with other pelvic floor procedures done with native tissue, so that we can best understand what the true incidence is for our patients. So how high should we set our limits for patient risks, and how should we compare them? So we know that at 9 years, based upon a study that's now quite dated, the risk of sling revision or removal for either erosion or retention was almost 4% over 9 years. But what is the comparator? And unfortunately, we don't know what the comparator is because, again, these are single arm studies with no comparator arm. And again, this is what we experience in long-term analysis of outcomes when we don't have the ability to look backward in time for both the experience of that surgeon and also the experience of that group of surgeons doing a new procedure versus their experience with older procedures. This simply looks at it was a well-done study looking at the risk of long-term risk of reoperation after synthetic mesh midurethral sling surgery for stress incontinence. And what this essentially applied, so the lowest line is reoperation for mesh removal, and then you can see the much more common risk was reoperation for recurrent stress incontinence. So one of the important things that I've heard my colleagues say is that meshes never fail. Well, indeed they do fail, or they're only partially successful. And when an operation is partially successful, then we have to ask the patient, is she happy or does she want more? And hence you see the increased risk of reoperation for recurrent stress incontinence over time as more patients develop atrophy. Perhaps the slings weren't working well to begin with, and that functionality became even worse. But the overall recurrent cumulative incidence of reoperation rate was not insubstantial in this particular study over time, indicating that, again, there is no panacea, no one intervention that is perfect for our patients with either pelvic organ prolapse or stress incontinence. Now let's consider another frequently used mesh indication in the pelvic floor, and that's the abdominal sacral colpopexy. And we know that utilizes proline mesh associated in a Y-shaped conformation on the apex of the vagina to the sacral promontory, historically done open, now almost universally done in a closed fashion robotically. And it's fascinating for me now historically to look at some of the long-term outcomes of the open versus the robotic procedures. And there's a clear learning curve in the robotic procedures, but there's also a significant risk of erosion with these type of meshes into the GI contents of the pelvis, even when the mesh is retroperitonealized at the time of the abdominal sacral colpopexy. So these are real considerations that we have to bring forward to our patients. The mesh risk is present there, and it's not as if native tissue is substantially better. It probably won't erode into surrounding structures, but the durability is probably better with the mesh. But the concern is, does the mesh cause significant local regional problems for that individual? And in fact, we've seen significant data now about abdominal sacral colpopexy and how high bars should be set in terms of the analysis of these procedures. And this was a large study of almost 230,000 patients undergoing pelvic organ prolapse surgery, looking at abdominal sacral colpopexy and understanding the risks of erosion associated with that procedure. And interestingly enough, there was a 10.5% risk of erosion with abdominal sacral colpopexies at 7 years, and that was erosion into the vagina. This did not consider erosion into the GI tract. And I personally have had 2 patients over my experience over the last 2 decades who've had GI tract erosions with time. So this is not a benign risk, and one that can put our patients at significant risk for complications. So what is acceptable? Well, again, what do we compare things to? How do we set the baseline such that we can best understand what to tell our patients? Well, I'll use radical prostatectomy as an example. We know that incontinence ranges historically from 2.5% to 69%, erectile dysfunction 50%, and need for a secondary genital urinary procedure around 32%. Is this rate acceptable? Unclear. Clearly, these rates, the higher rates now, are reflective of more dated literature. Incontinence and erectile dysfunction are much lower than this, but there are still enough patients undergoing radical prostatectomy, at least in the United States, even robotically, who still return with incontinence and erectile dysfunction, who require secondary procedures for management of those very, very bothersome conditions. So, again, what we must understand is how to assess these complications rates and how best to follow them with time. So as we look at long-term complications, I think we have to understand that long-term complications are a product of not only what the intervention is, but also, for instance, any thermal effect associated with that intervention. Certainly electrocautery can cause scarring and tissue injury and fibrosis. And then obviously the patient's own natural healing factors are additive. So a diabetic patient, a patient with significant ischemic issues, a patient with other problems such as rheumatoid disorders is much greater risk for fibrosis and poor healing, and even, for instance, healing with obstruction. And the best example of this, obviously, is the previously radiated patient who then presents for reconstruction either of a fistula or some other aspect of lower urinary tract dysfunction, which results in the patient having significant complications. Unfortunately, we still see a great many women who receive full course 5,000 rad radiation therapy for cervical carcinoma with then really recalcitrant fistulas and bladders that have become very functionally small with less than, for instance, 30 cubic centimeters or 60 cubic centimeters, and essentially you could repair them, but for what purpose? And so those patients obviously have to be considered for a urinary diversion. So I'll conclude by saying that we need standardized outcomes reporting that includes a follow-up assessment, the definition of what the outcome is, and the methods by which the outcome is reporting. We need a critical analysis of new technologies, and that's incumbent upon national groups, societies, and other group reporting agencies that essentially create registries to analyze new complications, new procedures, new techniques for purposes of understanding with time what the best is for our patients. And obviously, many technologies look very good initially, but with time, unfortunately, develop complications and risks that then reform our assessment of where that intervention should be placed in the armamentarium for the unique individual, or even if it should be used. And hence, we should have periodic reappraisal of new interventions for our various surgical interventions for lower urinary tract reconstruction. I'll conclude with two slides. One is thought to be the world's oldest olive tree. It's on the island of Cyprus. It's 3,000 years old and still producing olives and still alive. I'm sure it's seen a few changes in its time, and as I enter the last stages of my career, I have seen many changes in the field of urology, including the advance of robotics and other interventions that have really changed the whole field of urology. But keep in mind, robotics is not a benign intervention and does require a learning curve and experience for the unique surgeon, and also the ability for a surgeon who, as a mentor, can support that developing surgeon for purposes of reducing risk for patients and also enhancing the educational experience for that surgeon. So I'll leave you with this is a picture, but obviously it's reminiscent of your national flag. What I'm about to say may surprise you, but I know you look at my last name and you say he's Polish. I will tell you, I actually, on my father's side, am descended from approximately 10 generations of people who call themselves Ukrainians. My father was born in far western Ukraine, in Galicia. In those days, it was Austro-Hungary. My father was actually in Ukraine for the 1 year of freedom in 1918. And he was there when our enemies came across the border in 1918, at the end of 1918, to make it a part of the what is historically known in the United States as the Evil Empire. I will say that you're hearing a lot of craziness from the United States government right now that does not represent the feelings of many, many people, especially those of us who have a very special bond to your country. You're very brave. You have gone through great pain. I think the future is bright for you. I wish my father was still alive to see the country, because as a child, in the days of the Iron Curtain, I always heard him speak to me of the greatness of the Ukrainian people, the strength of the Ukrainian people, and the pride of the Ukrainian people. And I think you have proven to the world with your ability to stop a country so much larger and still protect the majority of your lands that the country is great. And I personally believe in your future. So I believe the appropriate terminology would be Slava Ukraini and Heroyam Slava. I wish you the best. Again, I thank Professor Mosiello for including me in this, and I wish you a good night, and I wish you peace, but peace with the strength of Ukraine in the future. Thank you.
Thank you, Professor Dmochowski. Thank you very much for this fantastic presentation that includes all, and thank you very much for your presence. I believe that the Ukrainian colleagues appreciated either your presentation, but appreciated maybe more your presence and your words that are in my mind, and believe also in their heart, and they're very, very significant. And Dr. Zymak, I don't believe that we have time for discussion, for questions. Maybe we can invite our colleagues and to send questions and to discuss in the next webinar. And I would like to leave you the podium for the closure. And thanks again, thanks to all. Dr. Zymak, please.
I'd like to say Heroyam Slava. Many thanks, dear Professor Dmochowski, for your support. We appreciate it very much. Thank you for understanding presentation and for sharing your experience on our topics today. Thank you.
See you on the next webinar, and thanks to be with us, and thanks especially to the organizer, to Omninet Ukraine, International Federation of Spina Bifida, and our EARN network, Urology, and Ithaca too, that supported this series of webinar. And we will come back in April with an interesting a topic that sometimes, many times is missing, but I believe that will be interesting for the majority of you. Thank you very much to be with us. Thanks. Thanks to all.
Thank you very much, and see you soon.